Thanks very much. Just so I know who I'm talking to, how many of you are primary care docs? Okay, pharmacists, nurses or nurse practitioners? Okay, so, and specialists? Well, I guess I know I've got a couple of fellows over there. Okay, fair enough. So, this is actually a really challenging topic, which drug combination. There are so many drugs available, so I'm going to try to present a fairly high-level kind of conception of the way I think about it. There are lots of issues that come up, and I think you probably, as I'm walking you through this, there probably will be specific questions that you come up with. Please write them down or store them up in your head, because we do have a good lengthy question period at the end. And when it comes to specific drug choices, you will probably get different opinions from different people. So the advantage of waiting till the end is that you'll have four of us to kind of ask, and you'll potentially get either the same opinion or different opinions. In terms of disclosures, I have done CME presentations sponsored by a number of companies that make blood pressure lowering medications. Some of these are a bit old, but I left them all in. The information that I'm presenting here, I believe, is evidence-based in the sense that there are studies supporting it. And this information I modeled off of the Hypertension Canada recommendations. And so it's been vetted, I suppose, if you like, by the Hypertension Canada Recommendations Task Force. So the objectives that I would like to try to touch on today are to review the current guidelines about selecting drugs for uncomplicated patients. Ross is going to talk about selecting drugs for complicated patients. We're going to discuss the emerging evidence for earlier introduction of single pill combination therapies. And then I'm going to give you my algorithm, the way I think about it when a patient needs more than one medication for blood pressure. So the first thing that Hypertension Canada tells us we should think about when we meet a new patient with high blood pressure and we're thinking about drug therapy. So obviously we've already thought about healthy behaviors and we're working on that. But because of the patient's risk level, we think a medication would be helpful. The first thing you think about are what are the risk factors the patient has? Do they have target organ damage? Do they have other disease processes? Because all of those things may allow you to customize the drug therapy. So for example, if a patient has nephropathy or heart failure, having them on an ACE inhibitor as the first drug would make a lot of sense, or an ARB. So that's the first question. The first question I actually ask when I'm thinking about pharmacotherapy is, does the patient have symptoms related to their high blood pressure? The reason I think about that is that allows me to say I think we need to get onto drug therapy sooner. And I think that from an adherence standpoint, if you give the patient a magic pill and their headaches go away, it is much more likely that they will stay on that magic pill for the rest of their life, and that they will not have trouble with adherence to therapy. And so I always say, do you have symptoms? Because if I can get rid of your symptoms, then I've won, hopefully from an adherence standpoint. Assuming that there aren't any compelling reasons to pick one drug over another, then you're into this category of what we're calling the uncomplicated patient. In my experience, many of these patients are very complicated for other reasons, but not because of their diseases. And then that gets you into this idea of we're going to pick drugs, and you're either picking drugs because the patient has both an elevated systolic and diastolic, or potentially if they're an older patient, they may have just an elevated systolic blood pressure. In general, I think about these conditions similarly when I'm actually thinking about drug therapy. So the new thing for 2017 is this is our sort of algorithm for picking your first drug. And the new thing was that we formally added the single pill combination. And actually the diuretic is missing from this slide somehow. That I deleted that. But anyways, there is diuretic on there as well, sorry. It's a long-acting diuretic is what the new guidelines say for 2017. I have to fix this slide. That's really bad. And so we've endorsed this idea that you can go ahead and initiate with single pill therapy right up front. And we'll talk about that. In terms of, and actually if you want to hear a little bit more about the whole issue of single pill therapy, I'm going to be talking a little bit more about that at the lunch symposium. So if you want to be fed, there's a lunch symposium, and I'm going to talk a little bit more about the single pill issue at that symposium. So there are a lot of very useful things in the fine text of the Hypertension Canada guidelines. The first one is say, use caution when you're initiating therapy with 2 drugs in patients where there is a higher likelihood of adverse events, frail elderly, postural hypotension, dehydration. There's some very interesting data that has come out of the SPRINT elderly subgroup. So they've published some data specifically looking at the cohort of patients in the SPRINT trial who were frail and elderly. They measured frailty based on how fast the patient could walk, gait speed, and it turns out that those patients actually benefit more when they have effective therapy compared to younger, less frail patients. And so frailty isn't necessarily an excuse to not provide therapy. It's an excuse to be careful in doing it. And I think it's perfectly acceptable to give two drugs in the SPRINT trial. These patients, actually, many of them were on 3 drugs. But how you do it and the way you dose escalate becomes an important consideration in those patients. Postural hypotension is a big problem, particularly in elderly people, people who've had long-standing diabetes, or people with Parkinson's disease. And so that is an area where you may actually allow the patient to have an elevated blood pressure in the sitting position, because when they stand up, it goes very, very low. And just from a drug therapy standpoint, patients with systolic blood pressures when they stood up of less than 110 were not even enrolled in the SPRINT trial, for example. Another sort of motherhood and apple pie statement that ACE inhibitors and ARBs are contraindicated in pregnancy. There are a number of studies looking at patients who conceive on an ACE inhibitor or ARB where the drug is stopped as soon as the patient and physician become aware that they're pregnant. And so far, there isn't a lot of evidence of harm if you are on top of that. But in general, my question for patients who are of childbearing potential is, do you plan to be pregnant? And if they say, if they are planning pregnancy, I don't start them on an ACE or an ARB. If they have no intention of being pregnant and there is a lot of benefit to being on an ACE or an ARB, either because they have nephropathy or heart failure or something like that, then I will use these drugs. But then I make sure, I warn them and say, if there's any chance that you could be pregnant, then we need to, be right on top of that, and you would have to stop these agents. Beta blockers still are not recommended for patients over the age of 60 as first-line therapy. They can be an important part of the cocktail, particularly if they have a compelling reason to be on a beta blocker, which Ross is going to talk about in a second. And obviously, if you're using a diuretic, then you need to be aware of hypokalemia. A patient should be informed that if you're taking a diuretic, and you consume too much salt, you are at much higher risk of developing low potassium levels. So when a patient shows up with a low potassium level and muscle cramps, generally the first impulse should be that it's the patient's fault for eating too much salt. And only after you've established that really the patient isn't eating a lot of salt, then you can kind of blame yourself and make an adjustment, consider using a potassium-sparing agent with the thiazide-like diuretic. We're not recommending routine use of an ACE and an ARB together, except for very specific situations, advanced heart failure, proteinuria. If you're thinking about monotherapy for a patient, if the patient is of African ancestry, they may not respond as well to ACE inhibitor monotherapy, and they may be at higher risk for bradykinin-related trouble, angioedema. So we're not recommending that, unless obviously they have another compelling reason to be on an ACE inhibitor. In terms of the things that Ross is going to talk about, this is the list of compelling reasons, and I think I won't, Ross will cover this, but it's there in the slides. And then there's a few other things. The global vascular protection is something to think about. I have some patients who are at high risk because they are dyslipidemic. They may have had previous vascular disease. They need multiple blood pressure agents. Global vascular protection is still something that's very valuable to think about. You will meet patients who say, "Doc, I can't take a statin and because I've had muscle pain or whatever." And this is a situation, if the patient's global risk is elevated, where you can use that information to help negotiate things with the patient. So you may say, "Listen, I would love to put you on a statin because it's a really effective way of lowering your risk, but because you can't tolerate that, we need to do an even better job of controlling your blood pressure." And so you can work with the patient and sort of do some trading off. So just a quick case to end my presentation. I think I've got 5 minutes. So a 70-year-old male comes in for a blood pressure check, and he's been avoiding salt and doing Aquafit 4 times a week. His home blood pressure is being dutifully recorded according to our instructions, and he's reporting an average blood pressure that's quite high at 160/85. He has a properly conducted sitting automated office blood pressure of 162/85, and somebody in your clinic stands him up and measures a blood pressure at 1 minute and gets 155/83. He has no compelling reason to pick one drug over another, and he's not currently taking any drug therapy. And he has no secondary causes of hypertension. So one of the troubles with our recommendations is that our recommendation slide that everybody loves, the image of the 5 drugs and then the single pill combo option, gives you the idea that it's pretty straightforward. You pick a drug and you start treatment, and you can pick almost anything in this case. The difficulty is that in most studies where blood pressures were effectively controlled, the patients needed about 3 drugs. And so the lie, if you like, is that it's okay to think about starting a single agent, and that's a reasonable position to hold. A reasonable position in a guy like this who's at least 20 points systolic above his target is that this gentleman needs 3 drugs. And so as you sort of think about what you're going to do in your practice, you need to be thinking not about, okay, what's my favorite drug to start patients with hypertension on? It's what's my favorite 3-drug cocktail that I'm aiming to get this patient onto. You may not actually get there. His blood pressures may come down with your initial strategies, but I think wrapping your head around this idea that we need to be thinking about the cocktail, not about the single agent, is the way to go. One of the ways that you can achieve more rapid, effective blood pressure treatment is to actually introduce the single pill combos early. And so a gentleman with a blood pressure that's 20 points above target at least, you should be thinking about single pill combination therapy, because it allows you to get 2 agents into that patient earlier, and it will actually simplify your prescribing behavior. There's good data showing that there's fewer side effects, better adherence to therapy with single pill combo versus others. Ross's STITCH study showed better blood pressure control rates. And we have a number of lines of evidence now looking at using single pill combinations early in the treatment of hypertension, showing reduced cardiovascular events, with the last study being the HOPE-3, where they were started on candesartan hydrochlorothiazide and ended up with a lower risk if they had hypertension. So the algorithm that I actually think about is, when I have a patient with a systolic blood pressure more than 20 points above target, I think they're going to be on an ACE or an ARB, they're going to be on a long-acting diuretic, and they're going to be on a long-acting dihydropyridine calcium channel blocker. That's what I'm aiming for. And rather than thinking of these as distinct entities, when I think about this, I'm thinking about them being mostly on all three of them. And sure, there's a few patients on the outlying of my Venn diagram that may only need one or two of those agents, but in general, many of the patients will end up on all three agents. So how can you operationalize this in an easy way in your patients? Well, in general, this is my scheme. I'm thinking about a guy like this is probably going to end up walking out on 2 drugs, either in a single pill combo or as separate agents. And you've got basically 4 ways to do that. You've got thiazide with an ACE, thiazide with an ARB, CCB with an ACE, CCB with an ARB. The second step in my algorithm actually simplifies things even more. Whatever class of drug I didn't start with, I add in my second step, so that within 2 pharmacotherapy decision points, the patient is on a very effective 3-drug combination for controlling their blood pressure. The ACCOMPLISH trial, I think, will be mentioned in this lunch symposium, but it sort of focused on the CCB ACE arm, showing that that's a very effective combination to use in high-risk patients. When I have patients that come in and they are already puffy patients, you know, maybe a little bit of pedal edema, they complain about sort of volume-related issues, then I'm likely to start those patients on a thiazide-based strategy first. If I have a patient who is borderline diabetic, has maybe dyslipidemia, has risk for gout, those patients I am likely to start on a calcium channel blocker based strategy first. And I think, you know, there are many other therapeutic areas where you think about doing combinations of treatment. You think about the COPDer on puffers, you think about multimodal pain control, you think about even diabetes where the patients need 2 or 3 anti-diabetic agents. And I would encourage you just to think, especially if the blood pressure is somewhat elevated above your target for the patient, that this patient needs a 3-drug cocktail and, you know, ACE or ARB, diuretic, CCB. I like to add the 3rd drug before I've gone to very high doses. So I will only go to middling doses of whatever my favorite drug is or my favorite single pill combination before I add in that 3rd agent in a second pill in order to minimize side effects. And then Ross is going to talk about specific indications for agents. So with that, I'm going to